Good evening, everybody. I can already see there are 60 people online. We'll not get into the details as to what went wrong. So we are good to go. And thank you for being with us for this, what we are now trying to call the Friday 8 p.m. sessions. We hope to make this a regular event for coming for every Friday. And this is happening courtesy some of the requests from
Dr.
people who,
Simantika.
people who are either appearing for exams or will appear for exams, as well as for routine people who are practicing anesthesia day in and day out. So some of the topics will be exclusively meant for postgraduate students, but they will always have a slant for use by the practicing anesthesiologist as well. Anyway, without getting into much of the nitty-gritties as to what we intend to do in the future, let's talk about what we intend to do over the next maybe a year and a half. Okay, so what we will do is we'll have two kind of sessions tonight. One will be the myths about fasting and feeding prior to surgery, which will be taken by Dr. Simantika Ghosh, and she also does anesthetized a few people who undergo general anesthetics here and there at Narayan Hridayalaya, but she is there to put to sleep or for providing anesthetic services for people undergoing the big transplants, liver transplants. Anyway, so she'll be talking about fasting and feeding, and then I will take over and take you through a very, very generalized topic about the anesthesia perspectives of enhanced recovery after surgery, which is essentially a little bit about what the RAS thing is all about, but more about serving as a template as to how to address any anesthetic management for any kind of surgeries that are going to happen. So I won't waste further time, and I will hand over to Dr. Simantika, take you through her presentation about the fasting and feeding during surgery. I hope, Simantika, you are ready.
Yes, sir. Thank you for such a nice introduction. Okay, so good evening, everyone. I hope I'm audible to everyone. So the novel coronavirus, it has brought us to this novel platform where neither can I make eye contact with my audience, nor can I find out if I'm making them yawn. Nevertheless, I'm extremely grateful to my teacher, Dr. Shoikat Sengupta, for providing me this first-hand novel experience. And of course, the HCV Forum, represented by Ms. Joyati, for this opportunity. So tonight, I'm speaking on a very simple topic. But before that, I would request all of you to please mark your responses to the poll questions. There are just 3 of them. How long do your ASAPS1 and 2 patients fast for oral clear fluids when posted for an elective surgery? 2 hours, 4 hours, 6 hours, or more than 6 hours? Okay. So the next one, do your patients receive intravenous fluids when they are nil per oral? The answers would be yes or no. Okay, so we have the next question. When do you restart oral clear fluids for your uncomplicated post-surgical patients? 2 hours, 4 hours, 6 hours, or more than 6 hours? Okay. So done. Most of them have, I think, attempted this. So we move ahead. Hope all of you have answered the questions. Now, let's go back a little into history and find out where this all started, the concept of fasting. Way back in 1883, Lister noted down that while it is desirable that there should be no solid matter in the stomach when chloroform is administered, it will be found very salutary to give a cup of tea or beef tea about 2 hours previously. However, in 1946, Mendelssohn, the one who documented the Mendelssohn syndrome, he found that vomiting during labor and obstetric anesthesia led to respiratory distress due to pulmonary aspiration of gastric hydrochloric acid. And there started NBM from midnight. Again, 1986, Maltby et al. Giving patients a drink of water up to 3 hours before surgery did not increase the gastric volume or acidity of gastric contents. The first death usually attributed to pulmonary aspiration following anesthesia was recorded in a young girl way back in 1848 and apparently occurred when brandy was poured in her mouth to resuscitate her at the end of chloroform anesthesia. In Mendelssohn's classic paper that introduced the concept of acid aspiration syndrome, he reviewed the notes of around 44,000 pregnancies in which 66 patients developed pneumonitis. But interestingly, even in an era lacking intensive care, none of them died from this. The only 2 deaths that were found were due to upper airway obstruction from solid food pieces. So now, why do most hospitals ignore guidelines on fasting before surgery? Even literature reviews show that patients are not following the adequate guidelines. They are inappropriately being fasted prolonged. Well, thanks to the myths that fasting from midnight is the best way to reduce the risk of vomiting and pulmonary aspiration during anesthesia, that the gastric emptying time of clear fluids is same as other liquids such as milk and coffee, and clear fluids ingested 2 hours before surgery can increase the risk of vomiting and pulmonary aspiration. That there is no harm in keeping patients fasted from midnight, and changing the fasting guidelines will cause confusion among patients and lead to cancellation of scheduled operations. Well, are these myths or facts? Let's find out. Clear fluids, water, fruit juices without pulp, clear tea, black coffee, and any liquid through which a newspaper can be read easily. That is the standard definition. When given within 2 hours of surgery, it benefits patients by increasing their comfort, decreasing their incidence of perioperative dehydration, hypoglycemia, and vomiting. Yes, of course, intravenous fluids given during the fasting period can correct the deficit, but it does not relieve the patient's dry mouth and feeling of thirst. Overnight fasting has been shown to cause post-operative insulin resistance and immunodepression. The measurement of cardiac output and oxygen delivery in this era has allowed the recognition of the detrimental effects of dehydration and has also prompted clinicians to extrapolate that a patient arriving for surgery in a dehydrated state was not only detrimental to the patient's comfort and well-being, but also had undesirable physiological consequences, even if they were otherwise healthy. This has led to numerous studies demonstrating that free clear fluids could be safely administered until 2 hours before surgery in adults. The incidence of pulmonary aspiration has been found to be low, with morbidity and deaths very much lower. However, the fear of aspiration and the concept that the longer the fast, the safer it is for the patient has led to excessive preoperative food and fluid restriction. In the 1980s, they developed an appreciation that excessive fasting is not only unnecessary but also detrimental. Gastric pH, as well as the volume of the contents, is important in determining the severity of any pneumonitis. But don't forget that acid secretion continues even during fasting. For clinically significant pulmonary damage to occur, a critical volume and acidity of gastric acid must be aspirated. These were set at 25 ml, that is more than 0.4 ml per kg, and a pH of 2.5 by Roberts and Shirley. However, these results were derived only from the report findings in a single rhesus monkey. So further systematic animal experiments were taken, and they suggested a higher critical volume of 50 ml, 0.8 ml per kg. Very recently, a 1.5 ml per kg limit has been promoted based on a pragmatic evaluation of the prevalence of comparable gastric volumes in nil-by-mouth patients and the very low incidence of gastric aspiration. Increasing gastric pH is not possible by dilution of gastric contents with ingested water, but highly effective and reliable increases are possible by reducing the gastric acid secretion pharmacologically, as with the addition of H2 antagonists. Reduction of gastric volume, it has been seen that gastric emptying has an inverse relationship with the calorific content of the drinks consumed, with 330 kilocalories emptying slower than 220 kilocalories drinks, and water emptying the fastest. So there is an approximate exponential decline of stomach content volume with time, with water having a half-life of about 15 minutes, beef extract 20 minutes, and tea with milk 25 minutes. This very well suggests that a 1 hour fasting time for water is entirely reasonable. Maltby et al.'s classic study, which has been replicated by others, showed no increase in volume or pH with a drink of 150 ml water given between 120 minutes and 180 minutes before anesthesia. However, there are relative contraindications to this 1 hour fluid regimen, and they include gastroesophageal reflux either being treated or under investigation, renal failure, some enteropathies, esophageal strictures, achalasia, diabetes mellitus with gastroparesis, and or surgical contraindications. So what next? Is it enough that we give our patients clear fluid, water, just 2 hours before surgery? Would that suffice for a good perioperative outcome? Let's see. Cuthbertson's landmark studies, all of us have heard about it. He described the catabolic state that accompanies bed rest and major surgery, with the later work characterizing the stress response and resultant catabolism and hyperglycemia. Parallels have been drawn between the energy requirements for postoperative patients and for athletes undergoing a major sporting endeavor. Both require increased oxygen utilization. If this process fails, there is a switch to anaerobic metabolism and accumulation of lactate, with the outcomes for both patients and athletes significantly impaired. It was therefore understandable that high carbohydrate diets well known to athletes should be tried in patients undergoing major surgery.